Get started. I'll take advantage of it. I want to welcome everybody to today's special presentation for the Institute of Global Health. I'm really pleased to introduce our speaker today, Dr. John Jubilee. Not yet. Ready to go, but I was going to say a few words about John. Several of us first met him about five and a half years ago on our first trip to Uganda that has led to so many collaborations. We visited him at his hospital that we're going to be talking about, the Hospital and Health Center, and what was so impressive was how much he was doing with so little. And I will only say that over the years since then, I think his workload has just gotten bigger, and I'm not sure that the resources have necessarily followed. With his team that includes other physicians, other healthcare providers, they provide a remarkable range of care, and he'll tell you about that, whether it's an extraordinary load of deliveries or the large number of patients whom they care for who have HIV, AIDS, or tuberculosis, or the other problems that affect Uganda and other countries in sub-Saharan Africa. For point of comparison, his hospital provides care for approximately 230 women a month who are delivering babies. Now, LA County once took care of about 20,000 deliveries per year, but with change in healthcare financing, my understanding is they're probably doing 1,200 deliveries.
24.
How many?
24.
2,400? 2,400.
200 a month.
2,400 a month. So it's roughly the same scale of deliveries in LA County as at the Mpigi District Hospital. So John is a friend of the Institute, and we've enjoyed working with him over the years that we've known him, and look forward to continued interaction. So John's a graduate of Makerere University School of Medicine and a resident of the district where his hospital is located. John.
I greet you all. Thank you, John, for that good introduction. I'll go right to what has brought me. I'm going to talk about Ugandan health systems. Those are my names. And I'll first I start by locating where Mpigi is on the maps. I'll give a brief introduction about myself. Then I'll talk about the Uganda health systems. I'll talk a little about Mpigi Health Center, that is some success stories and challenges. And as they say, the photographs speak more than the words. So I'll show you a few photographs of my clinic and compare my clinic to the other hospitals that are related to my clinic. So as you can see, this is the world map. I'm from right here, and right now I'm somewhere here. So when we get closer, have any of you been to Africa? Many hands. So when we get closer, then Uganda is here. We are neighbors to Kenya, Tanzania, DRC, and Rwanda, and Burundi. Yeah, to focus more, that is Uganda picked out of Africa. And that's where I am from. I'm still focusing on Uganda. That is our flag. very important symbol for us. It has those three colors, black, yellow, and red. Black for Africa, black Africa, yellow for the sunshine that we enjoy a lot, and red is really for brotherhood. White, black, all our blood is red. And we have that beautiful bird that if you come, you'll be able to see. It's very elegant, like most Ugandans are. So Uganda is a landlocked country in the eastern part of Africa. It covers about 250 kilometers squared land. It can be compared to the state of Oregon in the United States in size. When I was told I was coming to California, I was very excited. I have a few friends here. So I wrote to one of my friends. She's an old lady in Northern California. Told her I had an opportunity and had hoped to meet her. Then she wrote back and told me, California is so large. Many people think it is a small area. So I may not be able to see you. Where I live is, she said, 6,680 kilometers from where you will be. So I'll not have a chance to meet you, and I have not had the chance. This is a lady who suffers from liver cancer, whom I met in Uganda, and she's interested in natural chemotherapy, natural treatment. I'm also interested in that. Many of our people, if they got liver cancer, they would not live for another year after diagnosis. But here is a lady who has lived with liver cancer for some years in America. I'm sorry I will not be able to meet her. So Uganda is situated right at the equator. We have the mountain Rwenzori in the west part, and the highest peak is on Margarita Peak, which is about 5,100 meters above sea level. So we have some snow in Uganda also. The language is spoken officially English, so you can feel very comfortable when you're in Uganda. Although that your accent, many times people will not be able to pick you, but with time, English is the language widely spoken. We speak Luganda a lot. That's one of the tribes that is biggest in Uganda, and some Swahili, and many other native languages, about 50 or so. So I'm trying to locate you, to take you to Mpigi. We have moved from the world, we have gone to Africa, we have come to Uganda. Now we are in Uganda, and I'm trying to locate you where I live in Uganda. We have about 112 districts. Uganda is divided into districts. So Mpigi is one of them. It's quite here, near Lake Victoria. That is Mpigi again. So Uganda is divided into districts. You can imagine like United States being divided into states. Not of course, not quite that, but the districts are also divided into counties. Maybe like the California state would be divided into counties. Then the counties are divided into sub-counties. Sub-counties are administrative units with political heads, with systems of health, education, and other ministries. So most districts are named according to their chief towns. Like Mpigi is the Mpigi district, and the town is called Mpigi. I have already said this. The district will have a political head who is known as an LC5 chairman. Now, Mpigi district, according to the latest population, is about 250,000 people. It is a rural district, about 40 kilometers from our capital city. But that short distance can be a bit deceiving because the situation in the capital is quite different from what you'll see when you come to Mpigi. Mpigi is quite rural. There might be only one line or two lines of shops. So many people are just living on subsistence farming. Some of them are fishermen because we are near Lake Victoria. So let me talk about the health system in the nation, in the country. Of course, the health systems are all providers. Everybody who is concerned with, whose primary concern is to have the people healthy. And it is divided into the public sector, which is mainly supported by government. There is a budget that the government allocates to the Ministry of Health sector. Our budget, as you might have known, there is the Abuja Declaration, where each nation should have a budget of at least 15% allocated to health. But that's not what is happening at home. We get only about 6% of the national budget to health. So that public sector plays a role in providing health to the people. That includes the army, the health sector in the army, the health sector in police and prisons. That is all public. Then we have private sector. Some individuals have built hospitals. Very few have built hospitals. Others have clinics, and they treat people privately. So you walk in their clinic, and you have to pay for the services you get. Then we have the other sector is what we call private, not-for-profit. And these are very many. These are mainly faith-based services, Christian, Islamic, and other religions. So people have to pay, but they are subsidized a lot with support from outside. Then, not forgetting, of course, we have the traditional and complementary healers. This plays a very big role in our health system. Many people, before they come to the formal health sector, they will have visited somebody in their village who is a traditional healer. And these people use a lot of herbs. Sometimes we have bone setters, we have spiritualists, we have people who deal with teeth, and most of all, we have what we call traditional birth attendants. These traditional birth attendants. These play a very big role in delivering our women. Actually, the formal sector or the trained people deliver only about 50% of the women. So most of the mothers are delivered either at home by the older people who have delivered before, or they go to traditional birth attendants. But that, as you'll see, causes a lot of challenges. So we have two systems. There's the national, which is then decentralized to district levels. The national level is headed by the Ministry of Health, whose roles include formulating policies, looking after the standards, mobilizing resources, developing capacity, training, and epidemic controls. Many times we have epidemics. I'll show you that not very long ago, we had an epidemic of Marburg, because one Marburg case is an epidemic. You know this. And I was I was right in the backyard of Marburg. Marburg hit us and killed one of our workers. I'll be showing you some pictures of, when we were being prepared to fight it. So the national level caters for epidemics. And, they'll provide policy planning, mobilizing resources, and stewardship. So there are institutions at the national level, which include, we have only one national referral and teaching hospital, which is called Mulago, which is very affiliated to Makerere University, and that's where I studied. Then we have the National Medical Stores, that is an institution where all the supplies, all the medical supplies, that is medicines and other supplies, gloves, and other supplies, all come or originate from there and are divided into all those districts that I showed you and the sub-counties. So we have central supply. It's like there is a budget put where some of the units, like I'll be showing you, make a requisition and you get these supplies according to what budget you have. Then we have the Uganda Virus Research Institute, I think one of the best in East Africa, that we are able to diagnose some of these viral hemorrhagic fevers at home. Before it was not possible, because we would have to send our specimens to America, to Atlanta, but now we can be able to do this at home. We have a national blood transfusion service. So all blood transfusion is centralized. People can donate blood in the districts, but all this blood has to be taken to one center where it is screened, and eventually we have to ask for this blood to be able to transfuse people. And it comes with a lot of challenges, that kind of arrangement. I would like to talk about how the hospitals are arranged, how the arrangement of hospitals or the levels of hospitals. We have one national referral and teaching hospital that I've talked about. Then we have regions. So every region should have what they call a regional referral hospital. And there are 11 of these in the country, spread out. Below this, we have the general hospitals. Every district, each one of those 111 districts should have a hospital. But of course, many times some of them don't have. Then below the general hospitals, we have what we call a health center IV, which one of those I'm heading. It is a health center IV, but it also works as a general hospital for my district because there is no general hospital. Then below the health center IV are smaller health centers, 3. They call them health centers 3. There should be one at each county. And below those, there are health center 2s. One every, smaller place. I'll be showing you what population they serve. Then below this, we have a system in the villages, what we call village health teams. These are people, somebody was telling me, comparable to the barefoot doctors in China. People trained elementarily on disease prevention. Our biggest problem is malaria. So people in the villages are trained on giving messages, how to prevent what malaria is, how to prevent it. And in some cases, we have trained some of them actually to treat malaria in children. Because as you know, malaria will cause problems if it's not treated early. That's when people come in with complications. But we have a system where we train people at the villages and they are able to treat children under 5 for malaria and pneumonia and diarrhea. So that's how the system works. Okay, we had the national level, which is decentralized to the districts. Then the districts decentralize them to counties, counties to sub-counties. So the district is has this. It is required to employ. It actually hires the health workers, and it can fire. So I'm a district employee. The central area, the Ministry of Health, gives money to the districts, which pays my salary. But the district recruits me, and it could hire me. Of course, that causes some problems in discipline. So they also plan. They can also advocate for money at the district level. Of course, they work with teams. The districts have different departments, which of course would be related to health. We have, for example, education department. We have the agriculture department. We have fisheries, production, working on roads, and those all fit in, all come in to help the health processes. Then from the district, then we have what we call a health sub-district at the county, which health center I head. Here, also at the county, we also have to provide leadership to the lower units. We do supervise them, support them. In case the lower levels are actually not headed by doctors. That is, Health Center 3 are headed by what we call clinical officers, what would be here like an assistant physician. So we help them in support if there is, say, a procedure that somebody is not able to do down there. We go down sometimes to help. Say, for example, they can do some stitching. If somebody cut himself on the farm or something, that one doesn't have to come to my health center. It is done at the Health Center 3. We also help them in planning. And supervision, training the village health teams, because these are in the villages. We have each village is about 30 homes. You can imagine our homes are about maybe 10 people. So 30 homes would have 5 village health team members. So 5 people looking after all these people in the village. And we at the center trying to help. They tell us their problems. Many times we go into discussion and see how to help. Yeah, we have quite a challenge with human resource. So our resource package money is so little that the ministry has decided to focus on what we call minimum health care package. And this is in 4 clusters. One cluster that we focus on is health promotion, giving messages about health issues, disease prevention, community health initiatives, and environmental health and school health. The other cluster we focus on mainly is integrated maternal and child health. Looking after women who are pregnant, children under 5, immunization, growth monitoring, and the like. We also focus a lot. Most of our problems are actually infectious diseases that could be controllable, mainly malaria, tuberculosis, and HIV. However, we have what now is called a double tragedy. We have a double epidemic. We also have a lot of non-communicable diseases developing now. Hypertension, diabetes, cancers. So we have to deal with both the infectious and the non-infectious problems, mental problems, drug abuse, name it. So how are we financed? Like I told you, the ministry has a budget from the pocket, from the bag of the nation. We only get 6% of that. But the ministry tries to partner. There are many international organizations helping us. Thanks to the American people. There is USAID. I'm sure you have heard of this. United States Agency for International Development puts in a lot of money to help. A lot of things are actually donor funded. So these are the sources of funding: central government, donor, global funding initiatives. I must thank Dr. Jonathan Summit that I'm here is an initiative of this kind of funding. Then we have social health insurance. This has been a bit, I think this is what America is using mainly, but it has been very difficult in my country to use the social health insurance. If you were to use insurance, then you'd have to get it from the people who are formally employed. And these are very few people. Most of us are not formally employed. And people are very suspicious. They don't want to contribute money to insurance because many times this money sometimes ends in wrong hands. So it works, but not very well. The other way we are raising money is using what they call private wings in public hospitals. Whereas the government pays for every service that we give, some hospitals, from general hospital upwards, are allowed a window of having a private wing. Make a room look better and have somebody who can pay for the services. But my health center, by policy, is not allowed to do this. So our future plans is, of course, there is a problem that we have inequalities. Many of the service providers, the doctors who are few, the nurses run to urban areas. They are in towns and not in the village where most people need them. So we are trying to work around that, maybe pay people a bit better, I don't know, those who go to the rural areas. Then we try to involve the population in making decisions of what kind of health services they would like. So this only helps to structurally show you what I've been talking about. We have the community health services. Then we go to Health Center 2, Health Center 3. Health Center 2 is an outpatient clinic which is led by a nurse, and there may be about 2 or 3 workers, health workers. So it is an outpatient. They can treat malaria and many other of the common diseases. If somebody fails there, then she or he would have to be referred to a Health Center 3, which has a few beds, maybe 6 or so beds. So they can have an inpatient. But what is important here is that they can deliver mothers. There are midwives who could deliver mothers here. And this is led by a clinic officer whom we'd call assistant physician. If things don't work there, then they have to refer you to either the general hospital or to a health center. These work in conjunction with the district leaders, which we eventually call the district health services. After that, we have the regional referrals, which I have talked about, then to the Ministry of Health. This is only helping to amplify that system. At the village, you're serving about 1,000 people. At the parish is health center too. We call it a parish, 5,000 population. At the sub-county health center 3, about 20,000 people. Health center 4 should serve about 100,000. And then the general hospital, which serves sometimes about 500,000. Some districts are up to about 500,000. Then regional referral, about 2 million people. Then the national referral and teaching hospital, which is serving all of us, about 35 million Ugandans. These are some selected statistics for Uganda. You know, we are not doing very well in having our mothers delivering under skilled care. Even our maternal mortality ratio is quite high. It's very high. I'll be showing you some compared slides. Fertility, our women are delivering up to 7 babies in their lifetime. What is it for America? How many children? Maybe 2. Mm-hmm. The HIV prevalence is still quite high, 7.3. And in my area it's above that, it's about 10. So I have a few slides here to compare Uganda to some countries that may be familiar to you. This is maternal mortality ratio. This is by World Bank. I got this information, which made me feel a bit better, but you can see, they say we are at 360, but I've seen the home statistics tell us maternal mortality ratio is 438. But you could see, compared to Kenya, almost equally bad. Compared to Malawi, Malawi is worse off than us. But compared to some countries in the Latin America, you can see Costa Rica is doing quite well. But you can see Burundi is worse off. This is mortality under 5s. We are not doing very well. Just for comparison. This is infant mortality. Still Uganda is still high, very high. Yes, Uganda has one of the youngest populations. Almost 50% of our population are 15 years and below. So we have a problem, a big problem of adolescent or teenage pregnancy. And that comes with a lot of problems. Abortion is illegal in Uganda, and when the young people get pregnant, they are very challenged. They would want to stay in school. Many times they try out all sorts of means to abort. And many times they are coming in with very horrible situations. Yeah, this is talk a bit about life expectancy. This pleased me a bit. Yesterday I was telling some people our life expectancy is 54 years, but I learned that maybe we have improved a bit to 58. You can't see. The females everywhere seem to live longer than the men. Could somebody tell me why is it out there everywhere? The men seem to live shorter. But we are not doing very well. You could see Colombia, people are living to 70 years. Yeah? Burundi may be worse off than us. Costa Rica, quite good. People are living to 82, 78. My father died at 60 years. I'm 54. My mother died 82. So some of us can live quite, maybe I live to 82. Okay, this is nothing. So these are statistics for Mpigi Health Center, Maokota North, the one I had. So this is our disease burden pattern. For children below 5 years, malaria is the biggest issue. So this was for the year 2014, 2015. The burden was like this. Malaria, we had about 40% of all the patients that we saw having malaria. The other problem is a cold. A cold is not very bad. Many people will get over it even without treatment. The other problem is pneumonia. Then we have diarrhea. We have intestinal worms still out there, skin problems. The other challenge is trauma. My health center is situated near a road that is a highway, and so we get a lot of accidents. Many times they will ship in about 10 people with broken legs for whom I don't have much really to do, apart from doing some first aid, maybe stop bleeding or something. Then I would have to refer them. So there have been some achievements. We pride ourselves last year, 2014, 2015, for having done a very, very great job in delivering. This is from Mpigi Health Center. The national is about 50, but we were able to deliver about 80%, using the fewer hands. But this was because there was a project funded by USAID that brought in ultrasound machines to all the health center 3s. This attracted many mothers. Many mothers feel happy when you show them their baby on ultrasound machine. So many will come, and many of them ended up delivering with us. However, this project has ended, so I wonder if we shall maintain these kind of successes. Immunization. We test our immunization capacity by looking at DPT3, because that is like the last one. If people can come for this last one, then we shall know they will have come for the other ones. So 97 is quite a good success. I hear in America people are beginning not to bring their children for immunization, which is at home it's people want to immunize their children. I have been in medicine about 20 years or so. When I was a student, diseases like measles was a very bad one, very big killer. But now we have reduced measles very considerably. So mothers will always bring their children to hospital for immunization. Of course, there are some who are a bit skeptical, but very few. So we have a lot of people who come in to our outpatients. These are the services we offer at my health center, outpatient services. That means everybody will come in to this clinic, goes through the outpatient department, except the mothers who are pregnant, who will go straight to maternity if they are in labor, or if they are sick, then we treat them from maternity. They are given some special consideration, not to have these lines. Then we have HIV antiretroviral therapy services. I have a clinic that has about 5,000, we call them clients. I've been running this clinic for about 5 years, 6 years now. So people are on lifelong treatment. So eventually will become like family. I have actually seen some people, you can imagine about 6 years ago, people who were children who are 5 years are now becoming teens. I have seen them on ARVs grow. They are growing and they being able to live. Of course, there are some challenges, stigma, people not wanting to be known as having HIV. So some people have to cross from one district come to my clinic, and those who are near me have to go somewhere else where they are not known. Then we have maternal child health. This is one of my biggest concerns. Of course, like I told you, we are losing many mothers. John told you we are delivering about 230 mothers every month. We do emergency obstetric care, mainly cesarean section. About 40 cesarean sections a month in my health center. We have a laboratory. We also have what we call youth-friendly services. Like I told you, our population is very young. So we must have a service where we focus on the youths. Many times people don't want to be in line with their mothers or fathers when they are sick. So we have put a clinic that serves about 3 days a week where we focus on the youth. They have many problems, STDs, pregnancy-related issues, HIV/AIDS. Then we have maternity, of course, talk about delivering. I talk about theater because it's very important. That's the one that helps me to save some mothers. We have dental care. Mainly, it's real about extracting teeth that are caries. We give preventive messages, but what do they call it? The feeling, that one we don't do. We have mental health. Most of our biggest mental problem is epilepsy, seizures. That's our biggest. Of course, we have some people who have problems with drug use, some bipolar. We also have an eye care center. Challenges. The challenges I can tell you that, for example, my budget for supplies, that is medicines and other supplies, gloves, sutures, is about, did they say, I get confused, I get confused with the money. It's about 8 million Ugandan shillings for 2 months. That's about how much?
They said
$3,000, about. And this is supposed to serve me for 2 months, 8 weeks. But many times I'm out, I've run out within 3 weeks. So what do? The other 3 weeks we have to scratch. Many times we have to ask people to buy, because the doctors are there. We are 4 doctors. If you needed to do a cesarean section, I'm there many times. Of course, there are issues of power, but sometimes I'll fail to do a cesarean section because I don't have a suture. Yeah, because I don't have gloves. Sometimes, because I don't have IV fluids. They will have run out. So that's quite a big problem. The other challenge is infrastructure, space. These mothers that will deliver, where will they lie? Many times, actually, a mother will deliver, and we are not going to observe her as required. She delivers, if we think she's normal, within a few hours, 4 hours, she will be walking home, because other mothers will need to take her place. So we have problem of infrastructure, building, beds, financing. I have already talked about supplies. I have talked about transport. Many times I have to refer people that I can't handle. So I would need an ambulance. Luckily, an ambulance has been donated to me, but there are issues of maintaining an ambulance. Buying the tires for an ambulance will swallow all my budget. But somehow, we manage. So there are a few pictures that I would like to show you. So this is, I don't know if you are seeing these pictures, okay. Yeah. This is Mpigi. This is as you enter Mpigi. I think we are now going for outreach. Somebody is coming out of hospital. but you can see our signpost there. We have a very young population. These young people came to my health center to help us to clean this health center. Many times they do this. These are young people from an organization called the Watoto. They are mainly orphans. There is one American who has this organization that looks after orphans. So one day they offered to come and clean the hospital. I gladly received them. You can see the signature smile. So we have very many young people. We sometimes go to schools to educate, to test for HIV. Yeah, sometimes play games with the children. This is Swabble. Testing, of course, we are only allowed to test children above 13 years and above without their mothers. The other ones, it's trickier because then the parents have to give us the authority. But even for those 13 and above, can you imagine if you tested somebody and this child is HIV positive? Then it becomes really tough to reveal this and how to go on. This is about youth services. Now this building was donated to us by Irish people. This is where we run our HIV art clinic. That is a waiting area for HIV art services. It was also donated to us by somebody, a corporate organization. Same area, sometimes it can be very crowded. Same area. Yes, we are in the art clinic. That is a consultation room in the art clinic. Yeah, we have a lot of challenge of maternal to baby transmission of HIV. And there are many programs trying to counter that. So we are giving all the HIV pregnant mothers antiretrovirals. But it's very hard, we are challenged. The mothers come alone without their husbands when they are pregnant. So once you are tested and you are positive, we shall start you on antiretrovirals. But there are many issues around how to disclose to your husband and have him coming to get tested and have him agreeing to have you go through this process to be able to save the baby. So these are issues. This lady was being seen for that kind of issue. Yeah, we are still in the HIV clinic. You know, antiretrovirals, we count the pills earlier, so some people are quite healthy. They just come in to pick the pills every 1 month or 2 months. I'm trying to show you an idea of how our hospital looks like. I see Joshua shaking his head. He has seen this. This is in the general ward where we treat both men and women and children. We have one ward, inpatient. Show you some idea of our beds and how the inpatient would look like. Many times the male side is empty. Not because the men are not falling sick, but they have very poor health-seeking behavior. This could be, I think, maternity. This is still general ward, nurses' station. Maternity is very big. Babies are very big business to us. So this is a maternity. Joshua, you might remember, this was an old building. Actually, when your team came, we sat right in front of this building that now has been renovated by some Chinese friends. And that's why it's looking like this. And this walkway now that leads to the theater. Nurses station in maternity. This would be one day in maternity. We deliver about 10 babies, about 8 to 10 a day. Maternity, it can be crowded sometimes. Again, maternity, I think. Maternity. Many times it's difficult to bring in men to bring their wives. Many times they send them alone and they don't give support. But this young man was giving support, like you can see. I think he was very happy they have had a baby. Maternity again. Yes, I must be thankful to Institute for Global Health. One of the issues that is killing our children, our infants, is they come out prematurely. So we needed an incubator, which Institute of Global Health very well provided for us. But I've been challenged. I don't have space where to put this. And it is still neatly wrapped, and I'm ashamed actually. Because the incubator should be in a place that is not on the general ward, somewhere more clean, provide the warmth, but also avoid infection. I have still failed to find a place. So this gentleman is very happy taking the baby for immunization. We don't discharge. We don't send you back home many times until the baby has been immunized for polio and BCG, TB. So that is our outpatients. Yeah, waiting at the outpatients. Outpatient, this would be a pharmacy. Consultation room. Waiting at outpatient. A lot of crowds. I have visited a few hospitals here. I have visited the county hospital that I had been told may be similar to our situation, but I didn't see it. I didn't see this kind. So this is our laboratory. We have quite a lab with these machines, high tech, but we have a challenge. Many times we don't have the reagents. The power is out, but we have quite a donation also. Yeah, this is an area where we are immunizing children. Mothers in antenatal clinic. We see about 70 to 100 mothers every day coming for checkup. Growth monitoring. Yes, this was some training that some of us had to undergo about nutrition. You can see I'm in the middle there, listening very carefully, learning. Nutrition, breastfeeding. Many of our women are free to breastfeed. We encourage all the women to breastfeed exclusively for the first 6 months, then breastfeed for the 2 years. But many of the young people have to be taught how to handle the babies. I think this was one of such lessons. Yeah, this is when we were confronted by Marburg. That is me. I was supposed to be isolated actually, but I mean, I had to work also. So somebody's teaching me how to don this protective wear. Now I brought this picture to show what a situation would be in a regional referral. Many times if we fail, we have to refer to the next level. Many times we are referring to the regional referral, and their situations many times are worse than mine. So many times I feel very bad when I'm referring somebody, because you'll find a lot of, it's much more crowded there. This is also one regional referral hospital. Another, they are bigger than my clinic, but also the services are not as good either. This is a picture to show there was a camp for women with fistula, vesicovaginal fistula. It's a big problem. That's another regional referral. Thank you very much for listening to me.